one of the ways to get past this issue of not enough time is to accept the fact that you don't have to do everything at once. For example, when you're trying to learn a patient's story, that story can evolve over days, weeks, even years. And if you think that you can get it all in 15 minutes, obviously you're doomed to failure.
Welcome to Evening Rounds, a podcast that takes you behind the scenes in medicine. This evening, we are joined by Dr. Philip Gold. He has been a physician here at Loma Linda University Health for more than 40 years. Dr. Gold was instrumental in developing the specialty of pulmonology and is an integral part of healthcare history in our region. He continues to stay active in medicine, mentoring our next generation of physicians and connecting with patients through the power of story and his dog, Bo. If you like what you hear this evening, please subscribe. Well, Kelsey, we have Dr. Gold.
Amazing.
This is just a fantastic experience. I never thought I would get to interview Dr. Gold. So I have a very important question. You probably are the best person in this two-county area to answer that question because you've been a pulmonologist for a few years. Can you tell me, in an elevator pitch, so to speak, what is a pulmonologist?
A pulmonologist is a lung doctor. And when I started to become a lung doctor, there was no name for us. Actually, the American College of Chest Physicians actually put out a request to all of the people who professed to be lung doctors to pick a name. And one of the other names actually was respirologist, which they use in the United Kingdom. But somehow pulmonologist won the day, and I became a pulmonologist in 1966 or 67, somewhere about that. Pulmonologist is a doctor who takes care of lung disease, and initially they were doctors who devoted their practice to taking care of patients with tuberculosis. And so pulmonology, as it is now, is actually the first boarded specialty in internal medicine.
It's incredible that you've been in this for so long that it didn't even have a name yet. What are some of the things you treat as a pulmonologist?
Yeah. So what's in a name? The specialty really began out of the experience that doctors had treating tuberculosis, which was not only the major killer of people throughout the world in the early part of the 20th century and the late part of the 19th century. In the late 60s, maybe even earlier than that, developments in hospital medicine included the development of what's called mechanical ventilation. The breathing machines that existed earlier than that were not terribly efficient, sometimes did more harm than good, but technology had advanced to the point where there were really quite functional ways of helping people who could no longer breathe. Because keeping the lungs going was important, pulmonologists developed a major interest in critical care, and the subspecialty expanded. So to answer your question, in a very long elevator ride, basically pulmonary doctors now take care of patients with lung disease, to be sure, asthma, COPD, and interstitial lung disease. But a lot of them are driven by the excitement and the diversity that you get in a critical care unit.
You have had a legendary career here.
Legendary, it's a tall word.
but I think it's important for folks to know what you've done here on this campus. You've been here a few years, but you've also held many different roles outside the organization as well. I'd like to take us in a brief moment through Dr. Gould's medical career. I think it's really, really fascinating.
Yeah. Well, one of the things I think that you should know is my mentor at UCLA took a sabbatical when I was, I think, a junior resident. And he went up to San Francisco to the Cardiovascular Research Institute, which you're probably familiar with as a cardiologist. They offered him a job, actually. So when he came back to UCLA, I was working in his lab. I started as a medical student, actually, working in his lab. He said, "Would you like to come up to San Francisco with me as my first fellow?" I was, I think, the chief resident at UCLA at the time. And I said, "Wow."
Yeah.
And, the big hurdle was my wife, because she had to say okay, too. Anyway, we talked about it a lot. And I decided, with her blessing, to go up to San Francisco. And I had a number of really great opportunities. And my jobs were two. One was to build a pulmonary function laboratory, which was a really great experience for pulmonologists, because you have to learn about equipment and how it works and how to do tests and what the downsides are of testing and what you can learn from testing. But my other job was to start an ICU, because ICUs were just beginning at the time. We called it a respiratory care unit, was an ICU.
So you created that program.
Well, I didn't create it, but I was the scut worker that did all the hard stuff.
So you created it.
Yeah. One of the fun things, actually, was that this was just about the time that Jeremy Swan here at Cedars was developing this floating catheter. And my mentor, who had actually been more of a cardiologist than a pulmonologist when he was trained, got very interested and came down to Los Angeles and picked up a bunch of these catheters and brought them back to San Francisco. We spent quite a bit of time. At the time, the hospital unit that I was developing didn't have patients, so we had dogs, and we just practiced a lot with these catheters, seeing how they worked. And I'm a great dog lover, but I also think that animal research is very important in medicine. So I learned a lot, but in those days, a fellowship was different. You didn't necessarily apply, and there wasn't a time. There was no really
start date and end date.
Yeah. So some guys were fellows for 5 and 10 years.
Wow.
But I would say halfway through my fellowship, or maybe a little bit more, I got drafted, because this was during Vietnam War.
Wow.
At the time, if you were an internist, basically, you spent a year in Vietnam doing general medicine. And I didn't want to do that. I thought, learned all this stuff. I want to use it. So I went to Washington and actually talked to the Surgeon Generals in the Navy and the Air Force. And the Army guy said, well, I told him I bragged a lot, actually, and probably lied a lot, too, about how much experience I'd had as a lung doctor. So we have a possibility at Tripler Army Hospital in Honolulu for a pulmonologist, but you have to sign up for an extra year. And so I was in Washington. I called my wife, because it meant an extra year of our life, and she had no hesitation. She said, "You're crazy. You go to Vietnam for a year. You go to Honolulu for 3 years. It's not even something to argue about." So I took that job at Tripler, and I learned a tremendous amount, because we had an excellent house staff. There were no medical students, but great residents, and I learned how to teach there, I think, a lot. And I learned a lot about how to run a program. The chief of pulmonary, after a year or so, was reassigned to Letterman Hospital, so I became the chief, and required a certain amount of administration.
I wanted to jump in and ask you to expand a little bit on something you mentioned. You said you learned how to teach in your time in Vietnam and when you were in Honolulu. And you had also mentioned at the tail end of your career, you were brought back to be a teacher in the School of Medicine, and you obviously taught for decades in between.
Yeah, I think that the thing that really appealed to me initially about teaching was at the bedside. And I thought that that's probably was one of my strengths, was the ability to go up to a patient's bedside, never having seen them before, and talk to them for a while and examine them and hopefully teach students how to do an examination. And at the time, we used what was called the Socratic method of asking questions. To a certain extent, that lost favor for a while, and I think for some reasons, perhaps justifiably, but I also began to realize that there was a lot more to teaching than just making a diagnosis and telling people what to do, that basically there was a whole history of our profession that doctors needed to learn, that ultimately as an area called literature and medicine began to develop, that it seemed to call to me because I could see that there was great power in stories. Our patients actually communicate with us by telling a story to us, and being able to unpack that story and understand it and then make it clear to the patient what their story means is really a powerful way to help patients get through serious illnesses.
So that's interesting. You're saying essentially when they come in and they give you their medical history, kind of looking at it as though it is a story?
Yes.
Wow.
Exactly.
This is fascinating because I took exactly 0 classes in literature and medicine when I was going through training. Humanities are a very important part of my life. I studied it as an undergrad, religious studies and philosophy, and I took the bare minimum of science classes because I figured you were going to get enough science during your training. We often think that physicians need to understand the sciences. I would like you to build out a little bit more. You mentioned how important it is to be able to elicit a story and how to connect with your patient. Where have you seen the impact of literature and medicine in your own career and the physicians that you've mentored?
In my own career, obviously, one of the things that's been very important and also probably very enriching to me personally is the relationships that I've built with patients in practice that was over 40 years in duration. And I still communicate with many of my patients, and I'm sure over time that's likely to wane as all of us get older and feebler, but it was very meaningful. And one of the things that I believe helped me develop those relationships was learning how to listen, learning how to basically shut up and let patients tell me their stories. Like anything else, you can fine-tune it and embellish it by learning special techniques. And one of the ways that you can learn to listen better is to learn about the process of narrative and how narrative works, and what the beginning and the middle and the end are, who the players are. So the reason you didn't learn much about literature and medicine when you were studying medicine is, again, it's a relatively new area. The whole area of humanities, although it's been around for a long time, the number of medical schools that actually have formal programs for their undergraduates and graduate medical education students is pretty small. I'm not sure, because I've lost the thread, if that answers your question.
No, it does.
I just wanted to follow up on that. I've often told or had conversations with those that I mentor now that the patient will tell you, if you let them, what's going on. It is very hard for us when we ask that open-ended question that we're all asked to say, tell me what's going on, to actually let the patient tell you what's going on. It's 2 or 4 seconds. We often will jump right in and ask then another question.
Right. And this has been documented time and time again, and people who are interested in communication in medicine, that, doctors basically don't spend enough time listening. And there are lots of reasons for that. The area right now is under extraordinary time pressures, and that has changed a lot. And I resisted that. And part of that's okay, I suppose, but I'm sure there are a lot of people in the medical administration who were very frustrated with me because I didn't adopt a style of practice that we expect now of our doctors. And we evaluate them on their efficiency every bit as much as we evaluate them on the basis of their doctoring skills. And I know that you know this very well.
It's interesting to hear you say that, the investment of time is really what's going to have that impact on capturing that story and then the best patient outcome. I absolutely agree with you. I feel like physicians maybe aren't given a lot of that time. In teaching this and in seeing this now hopefully foster and grow here, specifically at Loma Linda, have you seen kind of the fruits of your labor? Have you heard a story from a student who said, you'll never guess what, this happened to me?
Yeah. Yes, I have. I mean, one of the things I continued to do after I stopped teaching in the ICU, which was probably a blessing for the patients as well as for me, was that I focused my teaching of our fellows in the clinic. And I watched basically as not all, but the majority of them adopted techniques that basically helped them communicate better with their patients and relate to them. And I think the most exciting thing for me and the most gratifying thing to me was when patients would come back to me, and if the fellow wasn't there, they would ask, where's Dr. So-and-so? And after our fellows matriculate and go on, some of them stay on, fortunately, but many go to other places. And I would have their patients come back and mourn their loss. So, I think I have basically been able to observe in a very meaningful way the fact that techniques can be learned. I think that part of it is actually in here. People have to have the will and want to relate to people in that way. It's a very important part, I think, of being a healer.
Here's an interesting question for you. After an answer like that, I can't help but ask it.
Yeah.
And I'm asking it because of folks who may be watching.
Yeah.
What would the Phil Gold at age 85 wish the Phil Gold at age 25 knew?
Well, that's a really thought-provoking question, so give me a second to think about it. When you're 25, obviously you've got hopefully a tremendous amount of future ahead of you, and you don't know what it's going to be like, and what the challenges are going to be like, what the successes are going to be like, and you become very impatient. And you sometimes push things to get sort of immediate gratification when the wiser course would actually be to sit back and observe and think and perhaps plan. So I guess my recommendation to me at 25 would would be to have faith. First of all, that things are going to work out all right if you take time and use all of the talents and abilities and strengths that you have, and try and develop those, make them stronger and better, so that you can take advantage of the opportunities that come your way.
It's interesting. We talk about not having enough time.
Yeah.
You've mentioned it, time with patients and time with teaching. And you told your 25-year-old self just to take some time.
Yeah. Yeah, and I think that in answer to one of the questions that you addressed earlier, I meant to say this. One of the ways to get past this issue of not enough time is to accept the fact that you don't have to do everything at once. For example, when you're trying to learn a patient's story, that story can evolve over days, weeks, even years. And if you think that you can get it all in 15 minutes, obviously you're doomed to failure. So, one of the lessons, I suppose, that I absorbed somehow was the understanding that you don't have to do everything in one step, that it can take time.
You're kind of going against the grain on that, because I feel like now in today's age, that is what it's all about, is doing all the things at once.
Yeah.
So it's really interesting that you're really reminding, I think, all of us, whether we practice medicine or not, to take the time and realize you may not get it all in that one sitting, and it may need.
I think the more experience you have, the more you understand the term triage. It applies in wartime and emergency medicine, but it also can be applied to what we do every day, and that is put things in perspective and do everything that you need to do at the moment that is going to be important to save a life or to improve a life, but recognize that over time you're going to, hopefully, if you follow through, get to where you need to be.
I feel like you've had a very long career. You've done a lot of teaching, you've done a lot of learning. Tell us a little bit about some of those early days. I've heard that you had a particularly harrowing experience with a woman in labor in a taxi cab. Tell us a little bit about that.
That's an interesting concept.
We were signed as students and as residents to work in an emergency room. The emergency room at UCLA Medical Center at the time was probably, as I recall, maybe a tenth the size of our emergency room is now. People would come to the emergency room basically for emergencies in those days.
It's a novel concept.
Yeah. But one of the things that brought people in the emergency was labor and delivery issues. And I was working in the emergency room at UCLA and was called actually by the front desk to run out to the parking lot because there's a taxi cab out there with a woman in labor, and she was in the process of delivering.
Wow.
And when I got out there, I found that the delivery was being impeded by her panties. We called it panty dystocia at the time. And so I was very knowledgeable about these things. The nurse gave me a pair of scissors, which I used to cut away the panties, and she delivered very easily after that. And it was my first, actually, of several deliveries. It was before I ever rotated on OBGYN, which we did at Harbor Hospital, and we actually went out there for 2 weeks and spent time there. And the reason we did is because they had so many deliveries there, and many of the women were multiparous, so they were easy deliveries, and it was kind of a wonderful experience.
So you talked about humanity for patients and humanity for physicians. How do you think spirituality plays into that? That's a big thing for us here at Loma Linda.
Yeah.
What does that mean to you?
Well, I always tell people that as a pulmonologist, the thing that really has to concern us most is spirituality, because the Latin term for breath is spiritus, and that's actually where we get the word spirituality. And if you think about the Bible says, "Behold, I will breathe life into you, and you shall live." It's on my license plate, actually. So I think when you are taking care of patients, obviously you first get involved because of the body, unless you're a psychiatrist. Something's wrong with the body. But you can't really separate the body from the spirit and the mind and soul, whatever you choose to call it. And it's by offering yourself up as someone who is not only aware of that, but willing to address that with patience, that you become a healer. And so I don't know if that is...
That was beautiful. Yeah. We could probably write a sermon about that. That was incredible.
There should be some mantras or missions out of that answer. That there's a lot there.
We do have one, to make man whole, right?
Yeah.
And it's simple, but it's true.
Yeah. Wow. You had mentioned the role of animal research.
Yeah.
And in that comment, I believe you said something to the effect that you're a dog lover, or you have something like that. So I have a Cinnamon and a Mario. I enjoy their company and their personalities, and they're both getting older. They're now in double digits. So my question, obviously, for you is, do you have a Cinnamon or a Mario?
Well, first of all, tell me about Cinnamon and Mario, and then I'll tell you about Bo.
That's awesome. So Cinnamon, they're both mutts. They're both rescue dogs. Cinnamon was picked out by my daughter Sophia at age 5, and Mario was picked out on the same day by my son Max at age 2.5. They both were able to name their dogs. So they were at the same rescue center. Mario was at the front of his cage, a little black dog, just itching to get out. And Cinnamon was in the very back corner of her cage. And honestly, it probably would have been unlikely that Cinnamon would have ever been rescued. The dogs that are sort of in the back that have just been in from a hoarding situation generally aren't those that are rescued. It's the Marios. And so Max immediately gravitated to the Mario. But for some reason, Sophia, and I think it's her sort of tender soul that she has, said, I want that dog back there. And so we took home Cinnamon as well. And Cinnamon has always sort of, even though Cinnamon's 3 times the size of Mario, she's a German Shepherd mix, and Mario's a little terrier mix, some Chihuahua and so forth. We got DNA testing because we were like, how do we model these dogs again after they pass away? But Cinnamon has always been the follower, even though she's much bigger, and I think it's because she was much more withdrawn. But they provide so much enjoyment to our family. We have chickens and cat as well, but those 2 dogs are, in fact, we are remodeling our kitchen, and we've made sure that there are 2 spots for their kennels, their kennel dogs, that they're moving to the new spot as well. So Mario and Cinnamon both have their spot in our place. So that's Mario and Cinnamon.
So Bo is sort of an afterthought for us. We've always had dogs ever since, actually, I was in Hawaii. We got a secondhand dog we brought back to California with us after I got out of the Army. And since then, we've had dogs, and we've rescued some, one from the pound in Riverside, and 2 that just one my daughter found on the street, and then it was obviously abandoned, and she brought it home. The other was a feral dog that was living up on a hill above our house and would come down to our yard when we weren't there, jump over our fence, which was quite high, I had a Labrador at the time, who was sort of a good old boy, and he welcomed her and let her eat his food, which is what she came down for. She kept doing this, and we finally saw her in the backyard. And if I would go out, she would jump over the fence, and she had created this like a den up on the hill where she lived. This went on for a long time, and my wife would come out with food and put it out, and she didn't seem to object as much to my wife. And after a while, she didn't get upset at all when my wife came in there. It took another 6 months before she wouldn't jump over the fence if I came. That went on for another 6 months before she actually would come and eat when I was there, and ultimately came into our house. And when she came into our house, she was basically ours. And
you really had to win her over.
Yeah, we took her to the vet and had her checked out at that point in time. And she lived with us for several years, actually, after that. She was quite old. And we're not sure what happened to her. We were gone, and someone was watching her and called us up to say that she was gone. And we got home. We looked all over for her, couldn't find her. She ultimately came home dragging herself, and the vets think she had some infection, but I think she was poisoned. Anyway, it was so sad. And, we decided we couldn't have any more dogs. The Labrador that we had when she first came had passed, and we thought it was too old and too sad.
Yeah.
And after about 6 months, my wife and I simultaneously looked at each other and said, "We've got to get another dog." And we, up until that time, we had this succession of Labrador retrievers. They're all males, and they're all 85 to 100 pounds. And that's a lot of dog to handle when you're 80-something. So I thought, we got to get something smaller. And I seen these Labradoodles. So they had a lot of Labrador in them, but they came in different sizes. So we got a medium. He weighs about 40 pounds. And I trained this Labradoodle a lot, and finally got her involved in as a comfort pet. I don't know if you've... And so she was going to local nursing homes and to hospitals around our area, and was, I think, a wonderful, wonderful comfort pet.
Did you take her?
Oh, yeah.
I love that.
You go as a team, and usually with a group, there are 2 or 3 groups of comfort pets. The one we belong to is called Rim of the World, because they're based up at Crestline. But that all stopped when COVID started. So he hasn't been going to make people feel better for a long time. And I think it's affected his personality. He just won't leave my side anymore.
He's your comfort dog.
Yeah, he's my comfort dog, indeed.
When I retire, I hope to do that. I think that's such a cool program. So many hospitals have that program too, or at least they used to before COVID, where they allow therapy dogs to come in or comfort dogs to come in. And I think it's got to be transformative for you too, to see their responses to Bo.
Yeah.
Bo certainly has fulfilled his role in life, it sounds like.
Yes, he's a good dog.
That's fascinating. I have so enjoyed this opportunity to hear about the other parts of your life, and just been inspiring for me, honestly. I'd like to end each podcast with the following question.
Okay.
This podcast is designed to be reflective and think about things other than crossing the T's and dotting the I's in terms of healthcare delivery, et cetera, which is why we chose the name Evening Rounds. And so I'd like to hear from you. When you hear that, what does it mean to you?
Well, before I tell you that, let me just say it's been a pleasure talking with both of you.
Thank you.
My anxiety has been allayed, and so thanks for being such gentle interviewers. The first thing that came to mind when you asked that question is something that happened when I first began at Loma Linda. I'd come and make rounds in the morning, but I would spend most of the day working at the VA. And yet, in order to feel comfortable that the patients that were in my charge, that Loma Linda were getting what they needed and that I was aware of what was wrong with them, I used to come back to the medical center in the evening and make evening rounds by myself because our staff was busy doing other things. It was basically seeing the patients by myself at night when there aren't as many people around. It was quieter, that I got to know the patients and hear their stories in greater detail because I didn't have any place I had to be. There were no meetings, and it's just a matter of ultimately getting home for dinner. So it was a time that I could spend that was quiet and reflective, and probably which helped me more to get in touch with the patients than any other experience. And I think that you chose the name Evening Rounds aptly because it's an opportunity to reflect and tell stories and hear stories. And you've already heard not just my story, but how important I think stories are in just about everything that we do in medicine.
I love how it circles back to story for you, even in the end. That's what we aim to do too. So that's really incredible to hear from you.
Great. It's a great thing that you've done, and I commend you.
Well, we are going to relish the words that you've stated here this evening and make sure that we continue to emphasize storytelling on this campus.
Right.
Thanks
Thank
again
you
for being here.
Thank you for asking me. It's been fun.